I would like to thank to the committee inviting us from Indonesia, especially from Gajah Mada University, in having a team. I'm getting old, so I would like to respect our future. That is the key. That is the key. So, in this opportunity, we would like to have Dr. Mahmud from Soenarto Hospital. Is anesthesiologist, and Dr. Rushini, I'm sorry, nurse, also from Soenarto Hospital, and the other team, my brother, little brother, little brother or big brother, Dr. Asid, and Dr. Ratna, and I myself just give introduction, and hopefully I can summarize the presentation. So that's why I think it's depends on our boss here, Professor Chai, Jian Chai, in chairing the session. Thank you.
Please go to the front. Go to the front.
Please, maybe you could go the center.
Thank you.
No.
I will be present with the intervention medicine for palliative care at Soenarto Hospital. And you know, the title will be the part of the intervention of Soenarto. Second, the ground principle of palliative Soenarto. Palliative profile of pain clinic at Soenarto Hospital. We have 3 services. The first, patient services, community services. We have research. Next slide. Here are the video about the interventional at Soenarto Hospital. This one? This one? Positive? Yes. So? Collaboration with the other department,
neurology, orthopedic, correctional education, for the student with treatment. The patient is the chronic pain, low back pain. We try to reduce the pain, prepare patient. Next slide. The general principle of the palliative care, that is all Indonesia. The acute total care of the patient, not responsive to curative therapy. And then control of the pain, this is important. And the other symptom, problem, physical problem, social problem, harm. The goal of the palliative plan, quality of life to the patient and the family. Next. There is the director of Soenarto Hospital, Samarkand, made official announcement established of the integrated pain clinic, many senior and many doctor to attend it. Next. We have vision. The vision is the becoming a reliable national referral pain clinic for comprehensive evidence-based pain medicine service for 5 years. And then we have the philosophy. The text, the Japanese philosophy, Mukoyori, Amparo, Amargo, improvement without medicine. Life has to be meaningful, useful. And then we have the motto. The motto is the stop pain, start living. And then we have the analog, pain-free, professional, applicable, innovative, comfortable, factual, friendly, effective, efficient. Next. This is the history of the pain clinic. Introduced John Polican. This is the multidisciplinary pain clinic. The pain treatment facility, we have the multidisciplinary, single discipline. And now, factually, we have the multidisciplinary pain clinic, only diagnostic and the treatment. Ideally, the multidisciplinary pain center with research and training. We have to choose the multidisciplinary and have advantage that we expected. Next. Pain clinic, hospital-based and soul-based. We choose the hospital-based. Next. The multidisciplinary pain treatment team, medical director, physician, nurse, case manager, psychologist, physical therapy, occupational therapy, counselor, and biomedical therapist. Next. That is the pyramid. The pyramid, the best ongoing improvement and modification. The second pyramid, the research and evidence building. The top, step, education and the training. This is the intention of the palliative medicine. The holistic management for pain service within hospital. Pain service including the anesthesiologist, surgery, psychotherapy, oncologist, pediatrics, internal medicine, nursing, admission, psychiatry, and pharmacy. Pain service have acute pain service and multidimensional pain service. Demographic characteristics of the pain service, acute pain service in Soenarto Hospital. Next, this method, epidural PC, epidural continuous, epidural intermittent, balance anesthesia. Next. For the respiratory pain service, we have the pain clinic in Soenarto. Totally the patient can increase gradually. Next, the BX, mostly the pain clinic, the pediatric. Next, diagnose. Next, the report the frequent treatment. Next. We have the modified of the analgesia stepladder. The analgesia stepladder, step 1, step 2, step 3. And this is the modified double ways or the analgesia. We have the step 4, the interventional treatment. Maybe the interventional treatment we can do the epidural spinal cord stimulation by spinal cord stimulation treatment, and the others are. We have the evidence-based medicine recommendation. Positive recommendation is score E1, A1 plus, E1B plus, and 2B plus. This is the positive recommendation. Good result. Good result. Nice. Next, for example, we have the patient interventional treatment compact regional pain syndrome 2B plus. Next. We have for example, the 3 cases same treatment during before and during treatment and after treatment. Depending also that they are still pain, severe pain, and then still pain because the severe pain. The after treatment, we have the activity, daily activity. Next, same patient, the other patient, same cases. Next, do you see? Yeah. Next. And this is the sport journal. This is important. The radio frequency ablation of the steroid candida in the patient complicated pain syndrome. This is good, very good. Next, the other sporting journal by ultrasound. Get it? Next, the thermal radio frequency steroid candida. Wow. It is safe and successful treatment for cancer. The patient with the post-mastectomy. Okay. Next. And this the other evidence base for treatment the upper abdominal pain cancer. 2A plus, the neurolytic plexus celiac block. Next. This is the pancreatic malignancy. We can use 2 neurolytic celiac plexus block with alcohol sickness 96%, 2 milliliter. 20 milliliter under getting coloscopy. Okay. Before, during, and after treatment. Okay. This is the sporting journal, the neurolytic, sympathetic in the management of the cancer pain, prostatic adenomas, multicenter site. Okay. Sympathectomy is currently used as the step 4 to the modified double rate analgesic level. Sympathectomy can be performed early before the second level. Next. The conclusions: sympathectomy before step 2 and or the double rate analgesic level to lead to better pain control, less opiate consumption, and a better quality of the life in the cancer pain. That is the sporting journal. The role of the neurolytic sympathetic block in the treating cancer pain. Neurolytic technique disrupt A delta and C nerve fiber. Next. Neurolytic agent. Next. There's the technique block. Next. Effective self-palliative treatment. Next. We have the community services, also in the hospital pain management plan. Next. We have the report. Next. Next. Take home message. The interventional pain management to be better pain control, less opiate consumption, and the better quality of life. Cancer pain. We have the multidisciplinary pain management, and we have the palliative care, and then regional services, resident services, community services, and research. Maybe we hope research together. Thank you very much.
Thank you for the opportunity given to me. Today I represent Cherish, Professional Role in Cancer Pain Management in Neuroward Dr. Sastrowijoto Hospital. The chronic pain continues to be a prevalent and distressing symptom described by patients during curative, palliative, and subversive of cancer pain. This patient is unique, and the process of controlling cancer pain evolves differently from time to time. And this is incidence in my ward, about 126 out of 360 patients, 35% experience pain in neurology ward at Dr. Sastrowijoto General Hospital. The most common diseases are cancer with brain and bone metastasis, and then nasopharyngeal cancer, lung cancer, breast cancer, astrocytoma, glioblastoma multiforme, and multiple sclerosis. And this is comprehensive pain management. If we assessment of pain in early, we can early intervention, severity of acute disease decrease, and preventing further consequence. And then it's advanced that intervention, severity of chronic pain is increased and consequently increased. This is the pain management non-pharmacological approach, and then pharmacological approach, interventional pain management, patient and family center care and education, and palliative care. In this, I'm focused in message therapy. Because this time is limited, so I skip this video. And what kind of patient will receive massage therapy? Massage therapy is given to the cancer patient with pain, especially those who are treated in neurology ward at Soenarto Hospital. Why? Because it is an effective strategy to relieve patient, especially physical pain and psychological stressor. and then intimate, especially in the crowded ward. No need for expensive investment and additional advantage. We can hear what patients really feel about our service. It is easy to be followed up by patient family and with no cost. Challenge: patient with cognitive impairment and then family do not want to continue the treatment or have less attention to the patient. This is the before NPS 3 and after NPS 2, sorry. And then in the breast cancer patient with brain metastasis, before message, and then after message. Okay. Thank you very much.
Thank you for the opportunity for me. My name is Ratna Dewi Puspita. I'm working in Palliative care with Dr. Asif. This is an inspirational case in hospital UGM. 49 years old woman with stage 4 metastatic breast cancer come to UGM hospital with breathing difficulty and severe pain. She has been trying to find palliative care for the last 3 years, but never find the right place to treat her needs. After being treated for 2 weeks in the UGM hospital, she said that you are not only taking care of my cancer, but also provide me with psychological and even nutritional consultation. There is no other hospital who gave me such comprehensive service. Unfortunately, when the doctor prescribed morphine injection to overcome the pain, the hospital could not provide it since morphine injection is not covered by national insurance system. Okay, this is what the overview about teaching hospital UGM and its potential, palliative care in Yogyakarta, palliative care in Indonesian healthcare system, strategies for palliative care service in UGM teaching hospital, and our proposal. Okay, about UGM teaching hospital. There are many monodisciplinary sciences in our university. There is vocational schools, other faculties, Faculty of Medicine. There's 3 schools: School of Medicine, School of Nursing, School of Dietitian. And for multidisciplinary sciences, there's multidisciplinary postgraduate school, master degree program on bioethics, and other master doctoral degree programs. On the multi-professional, we have UGM Teaching Hospital, UGM Dental Hospital, and Gajah Mada Medical Center. Okay. We have academical system. There are Sarjito Hospital, Class A Hospital, UGM Hospital, Class B Hospital, and we have other hospital satellite like and this is our human resource profile. We have doctors, nurses, and the other. Next. Okay, this is the human resource. We have specialists, GP or general practitioner, nurses, and midwives, other medical staff, non-medical staff. Okay, this is our staff. There's a surgeon, general practitioner. Okay, next. Yeah, we have a subspecialist consultant, doctors, hypertensive, and we have hospital accreditation by National Hospital Accreditation Commission. We achieve 5 stars level, and this is our directors, and this is Prof. Arif Faisal, our directors. This is academic hospital certification for academic hospital, and this is how we describe UGM teaching hospital. We have so many human resources, young human resources, highly potential, eager to learn, hardworking, and collaborative. Okay. This is the need and opportunities palliative care in Yogyakarta, Indonesia. Okay. The number of cancer patients in Yogyakarta, based on Sarjito Hospital data, is increasing every year. From 2000 to 2014, and it's increased again in 2015. Okay. Yogyakarta has the highest prevalence among other Indonesian provinces. It's about 4.1%. Together with yes, this is prevalence for breast cancer and then cervical cancer, together with Riau and North Maluku province. Next. This is the prevalence. Okay. The existing palliative services in Yogyakarta, most of the palliative care services are conducted as an integrated part of the common medical procedure, but not as special service. No hospital yet is dedicated a specific ward for palliative service. However, more work has been done to start the palliative treatment for patients like home care, clinic, etc. NGO working for cancer, we have GKI or Indonesian Cancer Organization, provide shelter and psychosocial and economic support, but not minimum biomedical support. Opportunities in palliative care in Yogyakarta, the increasing number of cancer patients and patients with chronic disease will inevitably increase the need of palliative care. Yogyakarta Soenarto Hospital has been appointed as one of the 5 centers in Indonesia to develop palliative care center. Local government and policy has been supportive to the development of palliative care. Okay, next. Challenges to palliative care in Indonesia, that the community paradigm of palliative care as an action of surrendering, and the healthcare professional paradigm shifting from curing to caring. Palliative care is not covered by the government insurance system. It's a political economy issue. Okay. Next, this is a national health insurance design. Palliative still has no place in the system. Okay. Government insurance office is the regulator, the Ministry of Health, and cost and quality control of healthcare services, health service regulation, like referral system, standard of quality like healthcare facilities, professionals, medicines, equipment, and regulation for healthcare costs or tariff. Okay. Strategy for palliative care services in the UGM teaching hospital. This is what we plan to make to palliative care team. We have a consultant team from specialist and nursing consultant with the coordinator. Dr. Adit is the coordinator. It's for outpatient and home care unit. We have hospital base and we have multi-professional team and social workers. This is our business plan. The preparation, we have team building, facilities, market mapping, evidence-based service-based research, and the initial implementation is for outpatient service and home care development program. And we program evaluation comprehensive evaluation, program refinement. And we hope the grand opening will be on March 2018. This is our strategic planning. The team has decided to start with the following criteria to start palliative care service at UGM Hospital. Stage 3 and 4 cancer patients, stage 4 chronic kidney disease, stroke and Parkinson, especially in elderly with minimum social support, and severe case of chronic heart failure. Okay. Conclusion: that palliative care is inevitably needed and should be included in the management of patients with terminal illness and other debilitating conditions. UGM Teaching Hospital has a strong intention and modality to start a comprehensive palliative care services in Yogyakarta together with AHS UGM academic health system. Continuous efforts should be conducted to advocate palliative care services to the national health insurance system. This is our proposal to the NTUH, training for medical doctors and nurses, especially in palliative care, certified training programs, research collaboration related to palliative care between Taiwan and Indonesia, and developing educational models for future programs in palliative care, especially in Indonesia. Okay, thank you.
So, the next presenter will be Dr. Aziz.
Yes.
Okay, please, your time is yours.
Finally. Good morning, everyone. In this next speech, well, it's not speech, it's a short, how you call it, reflection on what we already done with our palliative patients. I wrote this with Professor Soenarto. We are trying to get a new sense of how we feel about patients in palliative care. And while we have discussed that, we discussed their values on how they perceive our services in palliative care, and also we combine it with our discipline, bioethics, as one of the main important things in practicing medicine. Next. I have 3 cases, but since the time is very limited, I will go to the 3rd case. Next case. Okay. I will start with this case. A young couple come to see a doctor. The parents is from Aceh, the most impacted area with tsunami in 2004. So it's in the most west of Indonesian territory. Come to see us in Soenarto Hospital in Jakarta. We are in the Java Island with craniofagus, conjoined twin. So I need you to promise me before I show this next slide that you will not take any pictures of these patients, because the parents is not allowed us to spread it. Even me, I'm a doctor, but I cannot read this. Just figure this out. Okay, this is difficult. Then that's it. That's what I want. Next. 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 So the doctors, they already done 5 times. They operate this baby 5 times, just to make this baby, because before the operations, the baby is really stiff. Their head, both of their heads, and then we operate them from the dermatology, the operations, just to separate the babies, just to allow the baby to move a little bit with the head. Now these 2 babies can stand, but only one of them can stand, but the other just follow. Yeah. So it's really, actually I have the video, but I'm afraid that you will cry, because I always cry when I saw the video.
Then after 5th operations, the physicians call us, Prof. Soenarto, me, and also the bioethics team in Major Mother, and said that, okay, we've done enough. But we need you to decide. They say that we need bioethics team to decide, are we going further or not? If you say, if Soenarto said, yes, you can go further, then we go further. We will separate the people. If not, then we will not do it. So they give the chance to decide to us. Usually we are glad by this chance, so that we can contribute to medical proceedings. But for this kind of case, it's difficult. So we have discussed with parents and also the physicians. Next. And they asked us whether they should continue the separation procedures, because this is already the 5th, and the next procedures will be to cut calvaria, to separate the babies, and to make sure that the vascular and the brain will separate. But with the fact that 70% of the brain is joined, it will be almost a procedure. The parents, one of the physicians said that the parents should choose which baby they will keep alive and which one is not. Thanks. The committee proposed that the physicians and parents not to continue. We propose them not to continue. It is just a suggestion. It's bioethics. The beauty of bioethics is that we can only suggest. The doer is still patients, families, all their patients. We give you the moral reason why you should do this, do some actions, and why you do not have to do some actions. So we ask them to not to continue. However, the consequences of the decisions not to continue the operations is not less compared to the continuing the operation. If we discontinue the procedures, then the parents asking us about the social support. What about the palliative care? How can we help? Now they live in the hospital, so nurses help them, doctors help them every day, every time. But when they come home to Aceh, to the rural areas, they will live by themselves. The parents, both of the parents, the brother, the older brother of his babies, and his two babies. This 5 of them. Next. So this is we use the 4-box method to discuss. We spend 2 months to discuss this. Next. Next. And after discussing the situations, the parents ask us, what will be your decisions if you are in my position? That's usual questions that we always accept from patients or physicians. If you are in my position, then what will be your decisions? It's a trick question. It's a tricky question to ask as a bioethics. Next. What should we do? What should do all the things that we should do all the things that we can, and let God decide what is best for us. Let God decide what is best. So this is what the parents say to us. Just do it, doctor. Let God decide which one is live. If you ask me to choose them, I will choose Sakira. Is the baby who is not who is with heart conditions, because she's healthier than the other. Next. If they are separated, it will make us easier to take care of them, since there are no social support for us. I'm afraid that our neighbor will only consider my baby as an interesting attraction. This is the reason why we keep this case secret. They don't have, in Aceh, for example, for especially during nursing, there are no social supports. Next, the support will come from the community, I'm sure of it. But could you make me believe that it will last as long as my baby is alive? Now they live from the physicians who give some of their money to this family. Even in our hospital, the father of this baby, we give him job so that he can live in our city. But even though like that, it's not satisfied. Next. And finally, the father said, doctor, he said this sentence to me, doctor, death is better for my baby compared to the current condition. Next. I'm a father with 2 children, and when someone said like that, it's really bothering me. It's really show that how desperate the father is. So, but as an academician, I should learn from this case. What can we learn? What are the professional values that we can learn from this? Next. Usually when we discuss about bioethics, we are going to these 4 principles. Respect for autonomy, independence, normality, and others. But in social, it is in countries where Professor Vermesser knows this better, that these 4 principles it's not always work in our settings, not always work in our countries. We should act more. 4 is not enough. 5, it's not enough. We should act everything because we are peoples, we are communities with full of values. We are, all religions come from Asia. So we are the one who have moral values. I'm not saying that the Western has no value, but all religions come from this. We are the one who accept religions from God. So we are the one who really have the revelation of God. So we have to add these values. What kind of values do we have? We have to reinterpret what actually means by autonomy. Is there any autonomy for us in this? Because in Indonesia we cannot accept this concept. It's not always, autonomy is not always bad. It's usually people who can, autonomy is given to the family or relatives who can pay for the services. When we ask the patients, are you going to continue the procedures? And then they say, well, it depends to my father. He is the one who pays for everything. That's it. That's impossible for autonomy. Well, beneficent normalization is the core work of physicians. I think in all of the work we have this value. And justice we have slightly different concept. So Prof. Soenarto come out with the new sense of bioethics. Next slide. Next slide. Well, for now it's only second. Other than those 4 principles, we add another 3. First is belief in God of faith. This is the most important principle that we will propose to the world. That okay, autonomy is good, benefits of normality, ethics is good, but we are dealing with patients who has different moral values. And they have their own values. And religion is the highest value that people believe. So we as a professionals have to consider the belief. We have to be, believe that what we do is only the maximum effort and the result is always in God's hand. That's what we always teach to our students. And then number 6 is dignity. I hope we can add some important things. Human dignity is the core value of everything doctors and nurses do. Whatever we do, dignity, human dignity should be the number one. We cannot do anything to decrease human value, especially nurses, for example, when we are talking about, because there are jokes in clinics in the hospital that is decreasing human value. I'm sure you all understand what I'm saying, those kind of jokes. And then the last is truthfulness and honesty. It's what every individuals in the world, especially us as a healthcare workers, should do, that we have to speak truth and honest with ourselves. That's the 7 values that we would like to propose for the palliative care in Indonesia, so that we can work together in the same values, so that we can discuss among us, each of us, cases that and based on the values that we can share. That's the end of my discussion. Thank you very much.
Thank you, Dr. Aziz. And due to the time constraint, I think that probably Professor Soenarto, could we have your final remark for this session?
Is there any time?
Yes.
No, it's okay.
Yeah, please.
Thank you. I have 4 points. The first one, the main goal of palliative care is the quality of life. You know well that. Of the patient in dying peacefully and in dignity. Palliative medicine is the study of management in the end of life. Patient is dying, and palliative medicine could be implemented appropriately in the West as well as in the East countries. And the development of regulation and act in each country is very, very important for patient and for palliative care institution. And basically, Western follow the rational and scientific base, and Eastern more cultural and religion or spiritual base. On the other hand, individual palliative patient in the West and the East has the same goal, that the patient could dying peacefully and dignity in the present of the family. Number 2, the 7 values of a renewing sense of ethical issues. Hopefully it could be implemented. Education and training in palliative care should be part of healthcare professional competencies. Start from the undergraduate to graduate as well as postgraduate, and in a continuing professional development. Special training in palliative care also has an important issue, especially in our collaboration among institutions nationally, regionally, as well as globally. Thank you.
Thank you for Professor Soenarto and your wonderful team for such excellent presentations. And then I think that due to the time constraint, we have to move to the next section. And then let me introduce you, Professor Zhu Zhongxin, to serve as the moderator for our next section and introduce our next outstanding speaker. So, Professor Zhu, time's yours.
Good morning. I'm Dr. Zhu, Greater Institute of Medical Education and Bioethics, National Taiwan University. The next speaker is Professor Sun. He is professor in Department of Philosophy and director